Okay. We
So,
are
shall I
live.
start? Yeah.
We are live.
So, welcome all to the one more episode of the Late Night Retina. This is the episode 12, and we have very nice, interesting two cases which will be discussed on VKH, and one more is the CMV retinitis. So, today we have a very eminent panelist, Dr. Bhavik Panchal, who is the uh, consultant in the LVP, Visakhapatnam. And we have one more panelist, Dr. Chitranjan Mishra, who is a medical officer in Arvind Eye Hospital, Madurai. And still one more panelist is yet to join, Dr. Samendra Karkur, who is the assistant professor in the AIMS Bhopal. So we have two presenters today who will be presenting a very, very interesting and well-managed cases. So first will be presented by Dr. Surabhi Sane, who is the fellow in the medical retina in the LVP Vizag. So we shall start today with the first case. And Dr. Surabhi, can you share your screen? So all the people who are listening to the YouTube, you can put your questions in the chat box as you are doing a discussion will be good.
Are my slides visible?
Yes, you can.
Yeah. So thank you, Yossi, for this opportunity to present, and thank you, Dr. Bhavik, for helping me with this presentation. I'm going to present a case of acute VKH and focus on mainly the general approach to management of VKH. Yeah, so here was a 30-year-old lady who presented to us with blurred vision in both eyes since 1 week, associated with headache. Her best corrected visual acuity in right eye was 2436. And on clinical examination, on fundus examination, she had neurosensory detachments with subretinal fibrin, disc edema, eye limb folds, and similarly in other eye, similar findings were present, and visual acuity was 20, 40, and 18. So again, disc edema, eye limb folds, and multiple NSVs were present in this eye as well. On optical coherence tomography in both eyes, there were multiple NSVs with subretinal hyperreflectivity suggestive of fibrin, and characteristic finding of RP undulations was present, and hyperreflective dots and choroid were present. On fluorescein angiography, there were early patchy choroidal hypofluorescences followed by pinpoint multifocal leakages, and later there was a presence of disc leakage, and there was pooling of dye in the neurosensory detachments, which was more prominent in the right eye. Left eye, similar findings were present. They were less pronounced than the right eye. So we clubbed everything together. So here was a 30-year-old lady who came with bilateral drop in vision with headache. On clinical examination, there were multiple NSVs, disc edema, and on fluorescein angiography, there were pinpoint multiple leaks at the level of the RPE and RP undulations on OCT. So we made a diagnosis of Butai-Vogt-Koyanagi-Harada syndrome. So for VKH patients, we generally get the systemic investigations because we are going to start these patients on long-term immunosuppression. So we get complete blood count to rule out tuberculosis, systemic tuberculosis. We get the chest X-ray, tuberculin skin test done, and blood sugars and liver function tests. As this patient was already referred, she had the systemic investigations done already. So we started her on oral steroids, 1 milligram per kg. When following up after 4 days, clinically as well as on OCT, the neurosensory attachments had started resolving. Though RP undulations were still present, vision had improved significantly. So we continued oral steroids in full dose, that is 1 milligram per kg, and we supplemented systemic steroids with transeptal triamcinolone in both eyes, and also started the patient on azathioprine 50 milligrams twice a day. 2 weeks follow-up, the vision had improved further. In right eye, the neurosensory attachments had resolved completely, but in left eye, the NSD was persistent inferonasal to the disc and involving the macula. Though the RB undulations had resolved at this point of time. So we started tapering of oral steroids, 2 weekly tapering was started, and azathioprine was continued. At this point, unfortunately, the patient was lost to follow-up, and she turned up 2 months later with vision was stable like the last visit, but she had recurrence of disc edema and neurosensory detachments, and the RP undulations reappeared on OCT. This patient, we started on oral steroids and azathioprine, and we repeated transeptal triamcinolone for both eyes at this visit. And during through the next 2 months, the inflammation gradually resolved, and the vision was 20/20 N6 at 2 months follow-up with complete resolution of neurosensory attachments. The oral steroids were tapered very slowly, and low dose oral steroids from 15 milligram onwards were continued for a very long time. And over around 6 to 7 months, the steroids were tapered, and azathioprine was continued. So VKH can acute VKH can have varied presentations, like the bilateral cobblestone kind of neurosensory detachments is the most common type of presentation. If the inflammation is too severe, there can be exudative retinal detachment. It can also present only with bilateral disc edema. And a less common presentation is of a bilateral acute angle closure. It is important to remember about this kind of presentation because it is important to look for disc edema and neurosensory detachments in these cases. Also, if laser YAG peripheral iridotomy is done in these cases, it can actually worsen the angle closure. And anti-inflammatory treatment with steroids is the treatment of choice for these patients. So the main aim of treatment in VKH patients is to start treatment aggressively early and continue immunosuppression in adequate dosage for a prolonged time, so that we can achieve complete resolution of inflammation without any complications, structural complications, or sequelae. Like in this case, there was complete resolution without any structural alterations. Whereas if treatment is not started early, stopped in between, if there is poor compliance, and if the inflammation is allowed to go into a chronic stage, progressive patchy depigmentation, choroidal depigmentation occurs, and it is associated with more number of recurrences. The recurrences of inflammation, with the chronic inflammation, there can be complications of chronic inflammation. In anterior segment, there could be cataract and glaucoma, and posterior complications like subretinal fibrosis and inflammatory CMV can occur. The recurrences of inflammation can be posterior and anterior. Posterior in the form of neurosensory attachments reappearing with disc edema, and anterior recurrence is the more common with granulomatous anterior uveitis with mutton fat KPs and iris nodules as the more common presentation. Less commonly, it can also present with a non-granulomatous anterior uveitis with very rarely hypopyon and fibrinous anterior uveitis. The questions to panelists are, what is your management protocol? Yeah.
Sylvie, thanks, Sylvie. It's a very well classical case of acute VKH and very nicely managed, and you have shown a very good case if how it will be if you are treated properly, and not treated cases how it goes for, and complications of VKH very nicely shown. Thanks to that, Dr. Sylvie. So when you see this case of acute VKH, whenever you see a disc edema or when you see a multiple neurosensory detachments, what are the probable differential diagnosis you will think for when you see this case, and how you want to rule out? Dr. Chitranjan Mishra, can you add points on that?
Yes. Thank you, Dr. Sarath. So, Dr. Suri presented a very nice case, very good documentation. I must congratulate her. But unfortunately, not always we will have such typical features of VKH. So, in those cases, there will be overlap with other diseases, which we should keep in mind as differential diagnosis. The most common, like the number one differential diagnosis should be sympathetic ophthalmia, where we can rule out it easily by the history of trauma or any ocular surgery. Maybe a trivial cataract surgery also in one eye. So trauma and ocular surgery we should rule out for sympathetic ophthalmia. Then coming to number two, that is your posterior scleritis. In posterior scleritis, typical feature is pain. Unilateral, patient will complain of pain, maybe in the night or when he or she wakes up in the morning, and it is radiating towards the forehead or the head. So that is post-scleritis, and if we do ultrasound B scan, we will get a typical T sign. That's obtained fluid present T sign. Then coming to number 3, that is CSCR. CSCR can mimic actually with VKH. So the points in favor of CSR will be vision will be relatively good. There will be no movement of pain, no signs of inflammation or uveitis. And if you do FFA, you will get a kind of say inkblot or smoke staggly, not like VKH where we may get a typical starry sky appearance. So and the if you and hotspot obviously in FFA if you are thinking of VKH inflammatory etiology. And coming to the OCT findings, there are a lot of recent studies where in OCT they are telling that VKH, what are the points in favor of VKH? There will be convolution of the RPE, and there will be kind of folds of the RPE, and subretinal septae will be there, and ILM folds can be there, which can be appreciated in the fundus photo as well. However, OCT findings in favor of CSR will be kind of a more of a PED or a bulge of the RPE. So these are the points how to differentiate from CSR. Then coming to the infective etiologies like your say Lyme disease, Bartonella Hanssoni, cat scratch disease. These are the infective etiologies, and TB, of course, TB is very much rampant. So these cases you should take proper history, and maybe serologically we have to differentiate. And sarcoid, if you are thinking of sarcoid, we should do a serum ACE level, serum ACE titer. Then intraocular lymphoma, where we can have a neurological features will be present, though panuveitis can be present, but the typical lesion will be yellow subretinal lesions will be there in case of intraocular lymphoma. Similarly, another differential diagnosis can be uveal effusion syndrome, where the scleral thickening will be there. There will be exudative RD, which is over a period of subacute presentation. There will be no signs of uveitis in uveal effusion syndrome. Secondary metastasis is another differential diagnosis, where typically the picture will not fit with CSR, VKH or anything. You will get yellowish lesions, and you have to search for if the patient is little a kind of elderly patient, you have to search for a primary by the help of like whole body MRI or PET scan, something like that. Then APM-PP is another differential diagnosis, which usually can kind of overlap all the features. However, APM-PP, the anterior segment inflammation will be less inflammation than the VKH cases. And posteriorly, you will get typically the placoid pictures in APM-PP, not like the serous elevations in VKH. And the prodromal signs, though may be present in APM-PP, but it is little less severe than VKH. Another thing is your exudative RD because of malignant hypertension. That can also mimic sometimes. However, you can rule it out by taking the blood pressure. And as she told rightly, angle closure glaucoma due to drug-induced causes like topiramate and all. In those cases also, we can get serous detachment, which can mimic VKH, where we have to take a proper history of the drug intake of the patient. So these are the differential diagnosis and how to differentiate from VKH.
That's a very exhaustive differential diagnosis by Dr. Chitranjan, which has been done. But we should remember VKH is the most common cause of the exudative retinal detachment when we see. So just keep in mind of VKH whenever you see, even if you think is both eyes, if you see only neurosensitive detachment over the fovea, instead of diagnosing CSR, just keep in mind of VKH also when you see like that type of presentation. So coming to the investigations. So what are investigations you prefer, Dr. Bhavik, in this case when you see is a case of VKH? And do you prefer doing OCTA in these cases? Is it helpful of OCTA nowadays? Dr. Bhavik?
Yeah, so thank you, Sharath, and thank you, Subhi, for the wonderful case. I would like to share a small PPT on based on the points which, is it okay if I share a small PPT?
So, Surabhi, can you stop your presentation?
It's okay, no problem. Yeah. Can you guys see my slides?
Yes.
Yeah, because I thought this speaking, rather than speaking, showing it will be good for the audience to understand it. So if we look at the important ocular investigations in VKH, yeah. So serial fundus photographs definitely help in terms of what Suri mentioned as chronic depigmentation is one thing that we should try to avoid, and that means the treatment has failed, to be very honest in blunt words. OCT also helps us in managing or understanding the response to our treatment, and also in seeing if there is any recurrence or prognostication as well. Similarly, angiogram, if you have an ICG, both to diagnose the disease per se and differentiate, as Dr. Chitranjan mentioned, from various other differential diagnoses. And B-scan USG again to differentiate from posterior scleritis. And I'll come to Octa. I have not done many Octa per se for VKH, but definitely one of our mentors, Dr. Anirudh Agarwal, has published extensively on Octa and VKH. I'll be quoting his paper as well. So VKH OCT helps in diagnosis, monitoring, and diagnosing any recurrence of inflammation. So what do we look for in OCT? We look for, most important is the RP undulations and multiple NSTs with or without presence of fibrin. Fibrin is invariably present in such eyes, and the hyperreflective dots in the retina as well as the choroid as well. Hyperreflective dots in the choroid are a marker of inflammation and recurrence as well. Important clinical pearl here will be the disappearance of RP undulations is an objective criteria to understand when we can start tapering the oral steroids. So we have RP undulations as they flatten out. This is a good objective way to start tapering oral steroids. During follow-up, if there is recurrence, patient's vision may still be okay, but you can definitely find out if there is recurrence in terms of, if you do not want to go for invasive investigations like ICG angio, definitely pick up much more earlier than the RP undulation. Coming to B-scan, absence of the T sign and increased choroidal thickness, which is present in both the conditions, but absence of T sign or subcutaneous fluid helps us differentiate from posterior scleritis. FA is in terms of when you have a symmetrical picture of VKH or atypical presentation, extremes of age. So this is where role of angiography helps us in terms of the typical pinpoint leakages, very beautifully described by Surbi, what you can come across. Few other points are patchy choroidal hypofluorescence, what we see. Apart from the typical pinpoint multifocal leakages, disc leakage, and pooling in the later stages of angiogram. Coming to Octa, this is the paper which I was talking about. I want you to focus mainly on the early phase because that is where the authors have found that where Octa may have a role. So what they found is multiple areas of flow void which are present in the choriocapillaries per se beneath the RP Brooks membrane. And this corresponds to the ICG angio. So if you do not have the facility of ICG angio, do not want to do a non-invasive test, this is one way to go about. Yeah, and in recurrence, again, you have this multiple foci of choriocapillaries flow void areas which are lost and they come back when you suspect a recurrence. So these are the two instances where I think Octa can definitely help in such eyes.
This is a very well presented and very nice points to be said about our investigations and about how to differentiate the other conditions. So once you diagnose the VKH, so very well managed, Dr. Surbi has seen they are given the periocular steroids, they are given the oral steroids. So what are the management protocols and when to taper the steroids? And what is your preference of immunosuppression, Dr. Samendra? Can you put a points on that?
Sure. Thank you, Sharad, and a great presentation by Surbi. So the management protocols that we have followed over the years and taught to us by our mentors is basically initially you have to start the patient on high dose steroids. So the choice basically is between oral corticosteroids, which is 1 to 1.5 milligram per kg body weight, and some physicians prefer to give even IV methylpred or IV dexa. Okay, so basically initially for 3 days or sometimes 5 days, you can start the patient on high dose pulse steroid therapy, followed by 1.5 milligrams of oral corticosteroids until the signs of inflammation resolve, which have been beautifully shown by Dr. Bhave. So you can monitor the disease while the patient is on treatment, of course, with visual acuity combined with all the other ancillary investigations like disappearance of T sign on ultrasound B scan, OCT markers can be looked for, FFA can also be repeated. However, one thing I would like to point out over here is that if you do ICG at all, you should not look for disappearance of hypofluorescent areas, because sometimes these hypofluorescent non-perfusion areas, they take a long time to actually disappear. So other signs can be looked for resolution. Another important thing is that the recurrence, there's always a dilemma and confusion about when to stop steroids, whether to give immunosuppression or not. So the idea is that if the patient is not tolerating corticosteroids, then obviously the immunosuppressive therapy should be started as early as possible, because the effect of immunosuppressive therapy itself would take about 4 to 6 weeks. So by the time the steroids would be tapered, that is, most patients tolerate steroids for about 1.5 months. It is after that that they start developing problems. So if you start immunosuppressive therapy early in the course of disease, by the time their effect kicks in, you can start tapering your corticosteroids. Uh, so if immunosuppressive therapy is given, then we generally, there is no consensus on how long immunosuppressive therapy is to be given, but at least the patient must be counseled that it should be given for a period of minimum 1 year. Okay. And corticosteroids, if the patient is being treated on corticosteroids alone, then it is advised that at least the patient should be on corticosteroid therapy for 6 months, because the highest chances of recurrence are within first 6 months, more so in the first 3 months. So this is the, and of course the anterior segment inflammation is taken care of by the use of topical corticosteroids. And the choice of immunosuppression primarily is azathioprine in our practice, because methotrexate is of course, we cannot use it in reproductive age group, and we know that majority of these patients are women more than men, and in the prime of their reproductive age. So azathioprine has been in the dose of 2 to 3 milligram per kg body weight has been really effective in these cases.
Very nicely elaborated, Dr. Samendra. Yes, most of the people we manage, we start with oral steroids, and once the investigation comes and you rule out tuberculosis or this thing, we start also on immunosuppression. And as Dr. Samendra said, azathioprine is the drug of choice. If the patient is intolerant or having any problem, then we shift into mycophenolate mofetil as the second drug of choice.
Yeah.
So giving the systemic treatment, also we give periocular steroids, we are given intravitreal steroids, and also there are some case reports saying suprachoroidal steroids also has been tried, especially in the DME, not more in the VKH. So Dr. Bhavi, can you tell what is the role of those local treatment?
Yeah. So again, an important question in terms of what we read in the textbooks and what we see in the clinics is something different in terms of most of the patients with VKH, especially in the elderly age group. They may be diabetic or they may have other issues, intolerance to steroids. So in such cases, to start IVMP or give oral steroids may actually put them in a sticky situation where the diabetes may be uncontrolled, the sugars may just shoot up. So in such conditions, like especially if there is asymmetric presentation of VKH, or there's only unilateral presentation of VKH, patient having diabetes, which is uncontrolled or has some systemic infection as well, a pregnant female, or patient having a lot of acne over a period of time during a treatment, especially a young female and having a lot of acne, it's the confidence is detrimental to the confidence of that person. We have had one case of resistance to oral steroids. It's extremely rare, but there are cases in systemic literature where you can have resistance to oral prednisolone. So these are the situation where I would prefer a periocular or even an intravitreal steroid as well for management of VKH. In terms of suprachoroidal steroids, I have not had the experience. Again, used it for diabetic macular edema and BRVO through the other various trials which go on, multi-control trials. Not for per se for this thing for VKH. If at all want to give, might as well give intravitreal. That is my thought process. So definitely a very good alternative.
Yeah. So still the suprachoroidal one still has to, multiple studies has to go on for the inflammatory, especially the VKH, and this many studies are going on for the diabetic macular edema for the suprachoroidal steroids. And definitely the periocular steroids, it can be many people give as transeptal steroids or posterior subtenon steroids. They also work very well in the case of VKH. So whenever most of the patients, what they do, once the vision gets improved, they won't come back for follow-up. So Dr. Chitranjan, can you tell us the points which may help us to detect early recurrences when they come and how to manage the early recurrence? Is there any importance of RP changes you want to see in them?
Yes. So coming to the recurrences in these cases, as in the presentations is showed actually very nice pictures, But see, the recurrences we get most commonly the anterior recurrences. For example, anterior uveitis, anterior cells, flares, KPs and all we get. That is the most common variety. Second most will be anterior uveitis plus intermediate uveitis. Third commonly can be panuveitis in the recurrence, and least is only posterior serous elevation kind of pictures in the posterior segment only. So that's what in the recurrence we get usually anterior segment findings most commonly. Coming to the management of the recurrence, already it has been very extensively discussed by Dr. Samendra and Dr. Bhavik. So we have to step up the steroids. And one thing only I want to differ from rest two panelists. Here we give intramuscular DECA, IM DECA 2 cc, that is coming to be around 80 milligram. That we give for maybe first 3 days. Then depending upon the visual acuity and the inflammation in the eye. For example, one patient was maintaining 6/9 for a long time, and suddenly due to recurrence, her vision has decreased to 5/60, say. Then in that case, we will start with intramuscular DECA 2 cc, that is 80 milligram for maybe 3 days. Then we'll start with 1 milligram per kg, or sometimes like 60 or 50 milligram we start per day for maybe 3 to 5 days. Then it will be tapered to 40 for maybe 1 week, 30 for 1 week, then 20 milligram for 15 days, then 10 milligram for another say 15 days or 1 month. Then the lower dose will continue for over few months, as has been discussed. So that will be our management in case of a recurrence. And why we get anterior picture usually in recurrence, because we can just remember like that posterior segment is already the pigments, RP and all has been involved in the disease process. Still we are having the iris pigments left. So the anterior recurrence is more common than the posterior recurrence. Yeah.
Thanks, Dr. Chittaranjan. So we see that VKH in the young patient, in the old patient and all. So is there any difference in the presentation and management of the pediatric versus adult VKH, Dr. Samendra?
Okay, thank you, Sharath. Sharath, before I answer that, I'll just like to just raise 2 points, if you allow me.
Yes.
Regarding the non-responsiveness to the corticosteroids, we have had 2 patients in the past where the patient did not respond to 5 doses of methylpred. Okay, so we started the patient on immunosuppressive therapy concomitantly, but for a week there was no response at all. So ultimately, we went ahead with intravenous infusion of cyclophosphamide, and just with a single dose, the patient dramatically improved. So I just wanted to share that experience with the panelists and our audience. And another thing is the mycophenolate mofetil drug that Sharath you mentioned. What we have seen in our practice in India that the mycophenolate mofetil has lot of GI side effects in our population, and they don't tolerate the drug. And I have discussed this point with our counterparts in West, and they said that they find it more effective and the side effects are not so much. So I don't know, this is just a personal experience. That's it. Now coming to your question about pediatric VKH and the management, the literature says, and we have also experienced it, that in pediatric VKH, overall, the clinical course is very, very aggressive as compared to the adult VKH. And second thing is that in pediatric VKH, the chances of it presenting as panuveitis is much more than adult VKH. So in adult VKH, there's a likelihood of patient presenting only as posterior uveitis, posterior uvea, but in children, it may present more often as a panuveitis. Another thing is that in pediatric VKH, because of the inherent aggressive nature of the disease and the early onset in the life of a patient, that is, a child has so many more years to live. So the child has so many more years to develop complications such as glaucoma, cataract, and even recurrences. So the most important thing that we need to remember while managing pediatric VKH is that the institution of immunosuppressive therapy has to be without doubt in a pediatric VKH. In adults, you may get away with treatment just with corticosteroids if the patient tolerates, but in children, first of all, you have to minimize the exposure to corticosteroids because they are growing. So it can lead to so many hormonal problems, growth retardation, and so on. So the institution of steroids, immunosuppression has to be early, not only for as a steroid sparer, but also because the disease progression will be aggressive. So the treatment is going to be long term. So
Yes.
these are some clinical differences
Pediatric.
between pediatric and
Sarath, yeah, I would just like to add a point here. We
Yeah.
through this forum, we do not mean to say that. I think what Dr. Samendra mentioned maybe in a few patients, but with VKH, immunosuppressants need to be started at the initial visit itself, and
yes,
not
As early as possible, it has to be started. Yes,
yes,
that has to be
absolutely,
kept in the
absolutely,
mind. This is the general consensus which has to be taken
yes,
care of.
absolutely, absolutely.
So we have some questions by the audience. So Dr. Swarnim has asked, can we have both CSR and VKH together in the patient? And how to manage such cases? Any of the panelists can take this question?
yeah. If I may answer,
Sure.
yeah. So we had a patient of VKH. I'm not sure VKH with CSCR, but that patient had CSCR earlier and developed VKH later, and that patient eventually benefited with the intravitreal triamcinolone (IVTA). On similar lines, if I like to share, we had a patient subfusion choroiditis and who developed CSCR in the other eye, and that patient benefited with Ozurdex. So if you go back and read in the literature, there is I don't think there's any case report on CSCR post IVT or post Ozurdex. We need to just recheck that, but I cannot remember it off the back of my mind. So in such cases as well, if at all you come across that situation, uh, intravitreal or a local depot steroid definitely helps.
Yeah.
And it's possible. Critically, is definitely possible.
One more question was there by.
Dr. Sarath, just
Yes.
once again,
Yeah.
just to add to Dr. Bhavik what he told, like the reverse can happen. Or sometimes for the VKH, we started say steroid, maybe high dose. So additional steroid-induced CSR picture we can get sometimes. At least once we have seen it, once or twice we have seen. So that can also happen. What you told is the reverse, but you told about the topical local injection. What I'm telling, systemic steroid, high dose steroid can induce CSR in case of a VKH as well.
So miss, how will you get to know it's a VKH which is not resolved or it's a CSR? So when already you are treating it for a VKH. Dr. Chitranjan?
Yes, Sarath, please repeat.
Yeah. How will you know it's a CSR when you're already treating for a VKH?
FFA, the FFA pictures you will see the typical.
When you do a repeat FFA.
Yes, repeat FFA if you do, the typical either the implant or the smokestack picture you typically.
Okay. One more question was there by Dr. Divyansh, which is a very interesting question. So if there is a non-disc involving VKH, so whether the immunosuppression are indicated or not. And also he has asked one more question, how to manage in a pregnancy associated VKH. So one thing to say here, in the pregnancy, usually it's already an immunosuppressive condition where the VKH usually very rare to happen, but if it happens, it will be like not so severe. So if the panelists can take the questions.
It's a good question. If you have non-disc involving VKH, which is actually a very rare thing, because in all cases of VKH, you will see some amount of disc involvement. You cannot say that with posterior uveitis, which is so aggressive as VKH, does not have any disc staining or disc leakage. Okay, there will be some amount of disc involvement, and irrespective of basically focusing in your question, irrespective of whether disc is involved or not, the current standard acceptable treatment regimen is that you should introduce immunosuppressive therapy as soon as possible. Okay, because it not only helps in the management of inflammation, but also acts as a steroid sparer.
Yeah, thanks.
Okay. Yeah.
Surabhi, can you show the next slide? So, Dr. Surabhi? Yeah. So, just for the consensus of the audience, so management protocol, usually whenever the patients come, we start with oral steroids 1 milligram per kg body weight, or if needed also. Some people will start IVMP. Along with that, we can start periocular steroids and the topical steroids based on the anterior segment inflammation. At the meantime, we better to investigate for the MON2 and other differential diagnosis to rule out. So at the same time, we should start the immunosuppressive. So most of the times, majority of the people start azathioprine as a first line of immunosuppression, or they can start MMF also. So review weekly, and review clinically just to see how is the RP undulation, how is the neurosensory detachment, how is it resolving. So usually don't taper the steroids until there is a RP undulation is completely resolved on the OCT and the choroidal thickness and neurosensory NST is resolving. That time you start tapering the steroids very slowly and keep it at least 3 to 6 months depending on the how is the immunosuppression activity, other immunosuppressant you start. If there is a persistent inflammation and undulation is still persisting, then add local steroids also to the systemic steroids. It will be helpful for the resolution. So this is a very nice case which has been presented by Dr. Surabhi. So we should, next slide. So aggressive treatment with systemic steroids is the most important thing which need to take care for. Also the RP undulations. So just remember, just look for the RP undulations on the follow, and if it is resolving, that means you are responding to the treatment. So thanks, Dr. Surabhi, for
Sharath, I'll just add one last comment on this. There was a discussion about the recurrence, which can present as a posterior uveitis, anterior or panuveitis, yes, but more often it presents as anterior uveitis. So I just wanted to comment that the more there is a depigmentation of the fundus, the higher the chances of presentation as anterior uveitis. Okay, so it's basically, it kind of evolves from posterior to anterior uvea in cases of recurrences. That's all.
So we're already crossing our time. So thanks, Surabhi, for your very nice presentation. So we'll just go to the second presentation, which is by Dr. Bindya Doshi, who is a senior resident in the KBH Vacholi Eye Hospital in Mumbai. I welcome Dr. Bindya Doshi. Can you present the presentation, Dr. Bindya? Share the presentation.
Yeah, is my slide seen?
Not yet. Yeah, we can see.
Good evening, everyone. I would like to thank Yossi for the opportunity. So we had this 13-year-old boy who presented with sudden diminution of vision in left eye since 1 week. He was diagnosed with acute lymphoblastic leukemia 1 year back, and for which he was on maintenance chemotherapy at presentation. His best corrected visual acuity in right eye was 6.9, and in left eye it was finger counting 1 meter. Anterior segment, both eyes were within normal limits. IOP in both eyes was normal. On fundus examination, media was clear, disc was pink. There was presence of 1 to 2 disc diameter whitish yellow elevated wedge-shaped lesion along the vessels, just inferior to the disc, suggestive of with superficial hemorrhages, suggestive of retinitis. There was similar retinitis patch even supranasal to the disc along with the superficial hemorrhages. There was gross involvement of vessels, especially venular, especially veins, in the form of periphlebitis and perivascular cuffing in the superotemporal, supernasal, inferonasal, and inferotemporal arcades. This was the fundus picture of the left eye, which was which the involvement was more. Again, the media was clear, disc was pink. Similar large wedge-shaped lesion, whitish yellow with superficial hemorrhages, along with superficial hemorrhages was seen, suggestive of retinitis. There was presence of superficial hemorrhages and granular appearance of the fundus all over in all 4 quadrants. But the most striking feature was this, which was perivascular cuffing and periphlebitis, suggestive of and predominantly venular involvement, suggestive of frosted branch meningitis kind of picture. So at this stage, we had a 13-year-old boy who was on acute lymphoblastic leukemia maintenance chemotherapy, and who had all 3 forms of clinical manifestations of CMV retinitis in the form of hemorrhagic, granular, and frosted branch meningitis. So we diagnosed this child as both eye CMV retinitis with zone 1 involvement as well. And we did a quick consultation with the treating oncologist. He said the child was systemically all right, and he was systemically stable. We performed a CMV DNA titers, which was 9,830 copies per ml of blood. Child was started on intravenous gencyclovir 5 milligram per kg 12 hourly in 2 divided doses. Also, child was given intravitreal gencyclovir of 2 milligram per 0.05 ml in both eyes, as zone 1, which is 1500 from the optic disc and 3000 microns from the fovea. So as zone 1 was involved in both eyes intravitreal ganciclovir was given. 4 days after the initiation of the treatment, the retinitis lesion was coming down. Even the perivasculitis was improving. Similarly, even in the left eye, lesion was coming down in the size. Perivasculitis was also improving. At this stage, after 2 days, again one more dose of intravitreal ganciclovir was injected in both eyes. For 2 weeks, intravenous ganciclovir was continued, and there was significant reduction in the retinitis patches in both the eyes. Even the perivasculitis in both the eyes had almost resolved. There was presence of hard exudates at the macula in the left eye, suggestive of absorbing chronic subretinal fluid. Patient was shifted to tablet valganciclovir twice daily, and by after 4 weeks of treatment, right eye had completely resolved. Left eye was also doing much better. Vasculitis had completely resolved. There was some amount of smoldering activity in the form of small patch present, and some granularity was present in the periphery as well. Patient was continued on treatment till the lesion completely resolved and CMV DNA titers became undetectable. To our surprise, when patient presented 2 months later, patient had recurrences in the form of retinitis in both eyes just inferior to the disc. CMV DNA titers was repeated and it was 4,830 copies per ml at that moment. Patient was again treated with both eyes intravitreal ganciclovir as zone 1 was involved, and patient was also given intravenous ganciclovir for that recurrence. This way, this boy had 3 times reactivation in a period of 6 months. At every reactivation, at every episode, 2 weeks of intravenous ganciclovir was given, which was then later on changed over to tablet valganciclovir till all the lesions resolved and CMV TNA titer became undetectable. In total, in those 6 months, patient received 4 doses of intravitreal ganciclovir in right eye, and left eye he received 5 doses. 6 months later, both eyes had peripupillary CRA, both eyes stabilized. Right eye vision was 6.6 and left eye was 6.9. And after that, oral valganciclovir in prophylactic doses was continued till the completion of the maintenance phase of chemotherapy. This is how the right eye had completely resolved. There was no active retinitis or vasculitis. Left eye also was improving. This was the small this granular fundus had become CRA patches. Sorry, I don't have the last picture of the left eye, but left eye also eventually regressed completely, and there was CRA patches even in the left eye. So take-home messages from this case was that in leukemic patients, recurrences are common, especially when they are on maintenance therapy. So routine fundus evaluation is important in these children to look for the reactivation so that it can be picked up earlier and the prognosis is better. IgG, IgM, CMV in like serological test in these children may not be positive because they are immunosuppressed. So CMV DNA titers are quite important in monitoring their progress and treatment response. Also, CMV retinitis is a systemic illness and we must add systemic antiviral therapy. These are my some points of discussion. Systemic treatment should be continued for how long in such cases? We gave treatment till retinitis resolved and titers became undetectable. Still, patient had so many recurrences.
Thanks, Dr. Bindya. So it's a very well managed case and very nice case which has been documented, and it's showing almost all the variants of CMV retinitis how it can present. So most of the times we see in the immunosuppressed patients, in the HIV patients, we see the CMV retinitis commonly when the CD4 counts becomes less than 50. So what can be the other risk factors for the CMV retinitis to develop? What are the in which other conditions we can see a CMV retinitis? Dr. Samendra?
Thank you, Sharath, and thank you, Dr. Bindya. It was a wonderfully documented case. We know that HIV, especially with CD4 count below 50, is develops CMV retinitis, which becomes a defining disease for HIV immunosuppression. So apart from this, Non-HIV patients can also develop CMV retinitis, and the important ones that we see commonly in our practice are patients who have undergone solid organ transplantation and are on long-term immunosuppressive therapy. Second is we have seen patients of hematological malignancies, especially leukemias, who present with CMV retinitis, and long-term immunosuppression for any other disease also predispose patients to develop CMV retinitis. So these are the predisposing factors apart from obviously HIV.
So, like as I said, it is the mainly immunosuppression in the, any patients who are, especially the T cell. So
Yeah.
CD4 or the T cells which has been affected, we can see. And one more of the other condition also where we can see something called as combined systemic immunodeficiency syndrome or familial immunodeficiency syndrome. So where they are on, they can also develop CMV retinitis, where their CD4 count may be normal. So that time we need to go for the other titers like CD4 CD8 ratio and other combination, and as she said, CMV titers, everything has to be taken care for this. So, Dr. Bobby, can you tell us what can be the various clinical presentation of CMV can present with?
Yeah. So as rightly mentioned, and we were discussing about CMV mainly occurring in uh, patients with HIV and immunosuppressed patients. So if I can share my slides, Dr. Bindya, again, visual input will be much better
Sure.
to yeah what we just mentioned it. So I have a few slides on how a typical CMV retinitis can present. So the most common variant per se, what we see in the clinics is the fulminant necrotizing or the hemorrhagic variant. Okay, where you have sorry, one second. Yeah. Okay, so where you have the retinitis along with interspersed hemorrhages which are present. Apart from that, we can have the typical the frosted branch angiitis where the vessels or both the retinal arteries and veins can be inflamed, and there can be presence of inflammation along the vessels as well. And you have the indolent granular variant, which is mostly in the periphery, which does not have that much of hemorrhages and is one of the easier ones to treat. And rarely you can have the mixed variant as well. So apart from that, yeah, sorry for that. Yeah, apart from that, what we have to consider is apart from the typical presentation, sometimes there is a confusion or there may be confusion, especially to people who have just started treating senior retinitis or seeing them in the clinic, especially the fellows or the residents, is the differentiation between cotton wool spots and senior retinitis. So this is just a pointer or some clinical pulse. How will you differentiate a cotton wool spot or a patient, or in example, you have patients of HIV and HIV retinopathy, and you have a cotton wool spot. I'm not sure whether it is CMV retinitis or not. So cotton wool spot will have well-defined borders, whereas CMV retinitis lesions will have irregular borders. Cotton wool spots will not be associated with hemorrhages, whereas CMV retinitis, yes, it will be associated with intralesional hemorrhage. It is mostly nerve fiber layer involved. This is deeper retinal layers involved. Even complete retinal layers involvement might be there on OCT. There's lack of progression of the cotton wool spot, whereas CM retinitis, as we know, 24 millimeters per day, it is going to progress and commonly seen at posterior pole, whereas this can be seen in the mid-periphery and the periphery as well. Coming to the last variant of CM retinitis, which can be confused with a typical toxoplasma lesion, like in this case here. So what differentiates here is the presence of hemorrhages and the absence of presence of vitritis and the absence of hemorrhages in toxoplasma. So hemorrhages is the takeaway in describing a typical CMV retinitis because indolent form will be in the periphery and it is very different from how toxoplasma presents.
Bhavik, there was a question by audience. So, how to differentiate CMV retinitis from HIV retinopathy?
Yeah. So again, HIV retinopathy per se will start. One of the important clinical pointer here would be the cottonless spots in retinopathy. What we observe are boomerang in shape. This just you can observe it whenever you come across any picture of HIV retinopathy. Look at the cottonless spot. So they will have attenuation of vessels, few cottonless spots, but hemorrhages, intralesional hemorrhage will be extremely rare. It may not be present. The cottonless spot will not have hemorrhage within the lesion. That is a big takeaway point. Being on HIV and CMV retinitis, one more point I would like to add here is that CMV retinitis, both retinal veins and arteries are involved. But if you notice that predominantly arteries are involved in HIV negative patients. Okay, so patient who is having a transplant or secondary to ALL in this case. Whereas contrast to HIV patients, it is mainly periphlebitis or veins which are involved. So the answer why in HIV the arteries are not involved is something for your for a food for thought for you guys. You can go back and read about it. So that is from my side, Sharad.
Thank you. So Dr. Bindya has nicely said when she is going to inject intravitreal ganciclovir about when, because I can see in the cases what she presented, there was a zone 1 involvement. So what is these zones? Dr. Chitranjan, can you put us an insight? What are the zones we saw in the CMV retinitis and when we think of giving intravitreal ganciclovir?
Yes, yes. So, Dr. Bindya, can you share the slide,
Yes, sir.
the image? Yes, yes. So typically the zonal distribution is three zones, as you will see in the image: zone 1, zone 2, and zone 3. Okay, yes, yes. This is a very nice image actually. So zone 1 is roughly 3000 micron from the center of the fovea temporally, then 3000 micron superiorly and inferiorly. However, from the disc, it is 1500 micron only. So these points, if we join, this area is zone 1. Okay. Zone 2 is from the border of the zone 1 till the vortex bends, that is the equator, that is zone 2. Rest of the anterior periphery is zone 3. So why this zonal distribution is important? Because if the zone 1 or the posterior pole is involved, then the visual acuity is most severely affected because the macula is involved. Okay. And zone 3, if it is involved, and after that, after the lesion heals, there will be scarring, there will be holes, retinal breaks formation, and it will cause PVR, proliferative vitreoretinopathy, and retinal detachment. So that's why the distribution of the zones is important. And if the zone 1 is involved, we need intravitreal injection additionally in addition to the systemic management. That's why the zonal distribution is important.
Yeah, that's a very nice point to be seen in the zones which will help us to treat. Dr. Samendra, what is your treatment protocol for any CMV retinitis you see in your practice?
In our practice, the protocol that we follow is like Dr. Chitranjan made it easier for me. If it is a zone 1 involvement, then we supplement systemic therapy with intravitreal ganciclovir. So systemic therapy now,
For
the
the
advent
benefit of
of
audience, can you tell us the dose of the intravitreal ganciclovir you give?
we give 400 microns, okay, 400 micrograms of intravitreal ganciclovir, and the oral we combine it with Wellsite, which has made systemic therapy easier for us because of excellent bioavailability and compliance compared to the IV. So we give an induction therapy with 950 milligrams oral BD for about 2 to 3 weeks, and then we continue with maintenance. Another important thing that we must remember that we may try sole intravitreal therapy with ganciclovir, but that can be tried in cases. We have a publication by Dr. Ramandeep from our from department eye department from PGI. So they have shown that in cases which are non-HIV CMV retinitis, sole intravitreal ganciclotherapy may be effective in those cases. However, in HIV cases, there must be a systemic therapy plus or minus intravitreal therapy depending on the zone involved. I may just reply regarding the long-term treatment, like this case is about recurrences. So we must know that this is a virustatic drug, okay? All the antiviral drugs that we use are virustatic. So if a patient is developing recurrences, then the patient may even require a lifelong therapy with antiviral drugs, when even if the immunosuppressive stage is maintained or controlled.
Yeah, So most of the times, yeah, how you say only the local treatment is enough. But whenever you see a CMV retinitis in a HIV patients, or if you see a bilateral, it's
Yes.
better to give the
Better to give
oral,
oral. Oral.
because it's a neurotropic spread also. We should take care that
Yes.
optic nerve endol is not involving. So
Yes.
systemic treatment,
Yes.
I feel in CMV retinitis is most important. And the
Yes.
other very good
Absolutely.
point by Dr. Mohit Dogra has said. So we must also aware of two other rare conditions what we see in the CMV retinitis, especially in HIV patient who started on ART and the CD4 count is increasing. So we
Yes.
see immune recovery uveitis. So that also we should keep
Yes.
in mind in when we are treating these cases. And yes, definitely they can develop chronic retinal necrosis and retinal detachment also. So Chitranjan, your experience on using long-standing implant of ganciclovir, or you use intravitreal ganciclovir?
Intravitreal ganciclovir, as Dr. Samendra told, 400 micron. So there is a description that from 200 till 2000 micron you can give actually the safety range. There is
Yeah.
not much this thing. Even sometimes 4 milligram also they are given without toxicity. But our
Yes.
practice over here is 2 milligram in 0.05 ml or 0.1 ml, 2 milligram. The typical American Academy recommends 2 times in 1 week for 3 weeks as the starting dose, then weekly once as maintenance dose. Intravitreal, I'm telling, ganciclovir. And this is the ganciclovir injection. And there is also one implant is available, that is 4.5 milligram capsule. That you have to do implant is surgically with a non-absorbed suture. You have to implant, and that kind of 1 micron per day. It keeps on kind of discharging the drug. However, you have to replace it every 6 months or 8 months. And immediately after replacing that implant, there is kind of recurrence or kind of retinal detachment also happens. So you have to change it with another implant, then replace it. But honestly saying, practical, I don't have experience with the implant. We give injection only, intravitreal ganciclovir injection, 2 milligram.
Okay. So we know that basically CMV retinitis has a high propensity for the recurrence. Whenever the T cell count or the CD4 cell count decreases, they will recur. So even on the patient on who is the patient is HIV on ART, and suddenly the stop and the CD4 count is decreasing, or non-HIV patients. So when you will decide to stop intravitreal treatment or any antiviral treatment to prevent recurrences, and what can be the other possible side effects of these drugs? Dr. Chitranjan?
Yes, that's Sarath. So, like to stop the treatment, we should see the CD4 count. CD4 count should be 100. So, as Dr. Samina has told rightly, if it is less than 50, that is the risk factor for the development of CMV retinitis. So, if CD4 count increases by 50, or it reaches more than 100, or there is a kind of disease-free interval of 2 to 3 months. These are the three criteria. Another criteria is you will see clinically healing lesions. The lesions are kind of healing. They are not active, inactive lesions. So these are the criteria after which we will start. Will think of stopping the treatment. And regarding the side effect of the drugs, we know that the systemic drugs that we use, ganciclovir and ganciclovir, they cause most commonly kind of neutropenia and anemia and the hematosuppression. Usually they do around 10 to 12% cases. However, nausea, vomiting, and nephrotoxicity is there. But this one, other drugs like foscarnet and all, those are nephrotoxic drugs. So for the like neutropenia and anemia, these things, we can use the filgrastim. One neutrophil colony stimulating factor is there. That one is to be given to prevent the side effects.
So when the patient is CMV retinitis is on treatment, or once the CMV retinitis resolves, what all can be the other possible complications we can see, and how to treat that, Dr. Bhavik?
Um, Excellent points till now by Dr. Samindra and Dr. Chitranjan in terms, and Dr. Mohit as well in the writing in the chat box. So
Yeah.
coming to complications of CMV and management. Apart from the other complications in terms of not that vision or significantly important, the two major important ones are retinal detachment and immune recovery uveitis. So one which has reduced post heart era, whereas the other one has increased post heart era. So pre heart era, the RDs were much higher in terms of uh, percentage or incidence in CMV retinitis, whereas that has reduced post heart era. So what we, from the clinical point of view, what is important is the risk factors for RD include larger area of retinitis, number one. Number two is bilateral disease, and third is active retinitis near the vitreous base. So these are the three risk factors which you have to look for. And if your patient has this, do expect a retinal detachment. So these detachments are characterized by multiple retinal breaks, which are within the areas of active or atrophic retinitis. Okay, so either active retinitis can develop a break at the edge, or atrophic retinitis can develop different multiple large or smaller breaks which may develop within them. That is one point. Second point is, so obviously the surgically point of view, it's a little challenging in terms of the vitritis and all those things which are present, and the complications related to silicone oil and hypotonia. Not going into details of that, that's a different topic altogether. Coming to the second potentially sight-threatening complications, immune recovery uveitis. So this has increased or post heart era as the patient's uh, response or the immunity towards CMV increases. So what happens? What is immune recovery uveitis? There is excess inflammation inside the eye, okay, which may actually lead, which is detrimental to the eye in terms of vitritis, anterioritis, presence of CMV, cataract progression, or epiretinal membrane formation. So current definition includes 5 main criteria to, if you want to diagnose immune recovery uveitis: a patient with AIDS, receiving heart, achieving an immune reconstitution indicated by increased CD4 T cells. So you have to see the CD4 T cells. So if they're over 100 cells per mm cube for at least 2 months, that is one criteria where you have to understand that this may qualify as an immune recovery uveitis. Second is pre-existing CMV retinitis, but in the inactive state. And third is all of a sudden patient doing well and comes with just loss of vision. Suspect immune recovery uveitis. So the treatment is definitely is steroids itself, increase the inflammation per se to tackle this immune recovery uveitis, and continue with your antivirals for the CMV retinitis management. This is from my side. This is two major side
Thanks.
thing. Yeah.
Thanks, Dr. Bhavik. So, chronic retinal necrosis, Dr. Mohit has said how to diagnose chronic retinal necrosis. Actually, it is a severe occlusive vasculitis which we see in a seen in HIV patients, where there will be no retinal necrosis, according to him. So, usually these patients will develop with vitreous hemorrhage or neovascular glaucoma. So, we should be very careful in these patients and it's a very rare variant to see called as chronic retinal necrosis. To summarize the case, so this is a very well presented case of classical CMV retinitis, which can be seen in non-HIV immunosuppressed patients also. Okay, so in these patients, when we see, we have to keep them in both systemic and local treatment, intravitreal ganciclovir for a longer time, and based on the zonular involvement, we should keep it how to when to inject intravitreal ganciclovir. If it involving the zone 1 and zone 2, better to start it very early, and it has to be given twice a week for 3 weeks. Then weekly once has the maintenance dose. And if there is a recurrence, again we need to go ahead whether there is a CD4 cell count is there, and we need to start ART for HIV, or we have to increase it, or we need to start other treatment to increase the T cell count in the non-HIV patients. So I feel it's a very good presentation with a very good case and a very good discussion by all the panelists. I'm very thankful to you people.
Thank you.
Thank you.
Thank you, Dr. Bindya, for a
Thank you.
very nice case, very nicely presented.
Thank
So
you,
I
sir.
think we'll conclude our 12th session. So we'll be shortly we'll be saying when will be our next session. Maybe the topic also will be shortly set to all the people. Thanks all.
Thank you, everyone.
Thank
Have a
you,
good night.
everyone. Thank you. Thank you.
Yeah.
Night.